Hi, welcome everyone. I'd like to introduce a really good friend and colleague of mine. This is Faraz,
G'day,
who
guys.
is an amazing cardiologist working here at Nepean Hospital. And I've asked him to come along so that we can talk through a few cases. And we're just going to start off with this patient here who's got aortic stenosis. We're going to talk through about assessment of aortic stenosis. So, Faraz, I've got this case here that we were reporting on recently. It's not the best imaging in the world, but I was hoping we might ask you for a few tips and tricks on how to assess aortic stenosis. So, I guess it's a pretty challenging view to start off with, first of all, but maybe just tell
But
me.
that's okay. I think we not infrequently see suboptimal imaging because of patient body habitus, their inability to be positioned, and you have to work with what you have. So first thing would be to try to see if you can optimize this image by looking for additional windows, trying respiratory maneuvers, but say this is what we have in the end. Looking at it, it's hard to assess LV systolic function, but it looks to be preserved. My feeling is, and you measure this, but the LA diameter would be increased, and it's a surrogate measure. The aortic valve, though poorly visualized, looks to be calcific, thickened, and the word we would use is sclerotic, and it's very difficult to look at excursion here. Importantly, the RV is not enlarged, it's functioning well, and there's no pericardial effusion. So I've got a rule of thumb about parasternal long axis images. What I say is things that are usually going to kill the patient and embarrass the cardiologist often can be seen on parasternal long axis imaging. And what I mean by that is a big effusion, which is compressing your RV, a big blown out RV, which will tell you that there may be a pulmonary embolus or severe pulmonary hypertension, cardiogenic shock, which is a beta LV, or either critical aortic stenosis, or if you go up one rib space, looking at the ascending aorta, looking at it for a type A dissection. So what I say is just spend a bit of extra time on your parasternal longs, because most of the real red flag things are usually picked up in that view.
Awesome.
So let's keep going.
Should we just try? So give us the zoomed in view of the aortic valve, because obviously that was, as you said, we were worried about it being.
So this is a good zoom view, and this is exactly what you want to do for specific reasons. One is to calculate an LVOT diameter. Given that you're going to actually be squaring this measurement to estimate your LVOT area. And here we can see, again, a thickened calcified aortic valve with minimal leaflet excursion. Calculating the diameter may be challenging here with the degree of calcification.
Yeah, so this is what they came up with. Can you, again, just give me a critical analysis of this image?
Look, I think it's reasonable given the degree of calcification around here. Couple of things with this. I think you have dropout around this region here, basically, which may be underestimating it. But as a rule, I tend to say 1.6 to 2.4 are reasonable LVOT diameters. If you are beyond those boundary conditions, you have to look at a patient. Now, if you've got someone that's 6'7", you may have a larger LVOT diameter. If not, then you have to be really realign to get better views and see if you're extending into where there may be imaging dropout and it might be smaller.
Because this lady was in a 76-year-old lady, I think it was, who was not 6'5". So again, my first thought when I saw this was potentially they've overestimated, and as you said, and then they're going to square that, which has the potential of giving us inaccurate aortic valve areas.
And here, what it's going to do is actually underestimate the severity of the aortic potential aortic stenosis. So I would be looking to potentially go up a higher rib space, change your imaging around. And the other option you have, if you have a three-dimensional probe, is putting a what we call X-plane if you're using Phillips, or a multi-D slice through here. And what you'll often find is that our fundamental assumption that this is a circle is incorrect, but it's ellipsoid in nature. And you can get a better assessment of diameter, or actually trace the area out yourself. So those are other tricks.
And you do that with transthoracic 3D?
With transthoracic 3D, and what you can do is at the tip of the aortic valve, putting it through, you can actually planimeter the aortic valve, knowing you're right at the tip.
But again, you've got to have decent looking,
good quality images in order to be able to do that.
I guess one of the other things I was saying to look at is make sure they're measuring it at the right time in the cardiac cycle, mid-systole.
Absolutely.
And just the same thing, make sure that you're not too far into the aortic valve or too far back. I think they talk about either doing it at the insertion of where the leaflet tips are into the LVOT, or at least 5 millimeters before it. Which one do you do? Because the ASC guidelines, they talk about 5 millimeters before. Other people talk at the leaflet tips.
Look, I must confess I do it at the insertion of the leaflet tips, because they're easier to benchmark. the reason the ASC guidelines say that is because that is where you do your pulse wave for your gradients. And in order for your continuity equation to work, you want the diameter at where you're pulsing.
Yeah. And I always thought it was like, when you want to, maybe we can flip to that now. Like if you look at the LVOT, that is not the LVOT. If we go to the LVOT trace, we often talk about when you see that closing click. You know, you've got to make sure you see the closing click. You know, and again, this isn't the best image in the world, but you want to see that closing click. And for me, that's when those valves are closing.
Absolutely. So the main reason I use the valve insertion points is it's an easier benchmark and it's easy to be consistent with it, basically.
Yeah. Nice. All right, well, while we're down here in the apical 5-chamber view, so I guess let's have a look at some of this. So this was some of the first views that we're going to get for assessment of the aortic stenosis. Let's go from here. So apical.
And I think probably there's two important points here. Is that your LVEF is preserved, which means you're not dealing with low flow, low gradient situations where even a low gradient can be a marker of severe aortic stenosis. And two is that you have a reasonable cavity size. So whenever I look at the 4-chamber view and your cardiac function, to make sure that a mean gradient of 20 or 30 may not be low flow, low gradient situation. So I can be confident that I can rely on the numbers that I'm getting.
Nice.
And I can look up the guidelines and be sure that these numbers reflect the system.
So make sure that we've not got low flow, low gradient aortic stenosis potentially. Make sure we don't have pseudo severe things like that. Yeah, cool. And we'll maybe talk about those another time. So here's the apical 4-chamber view. We can then tilt up and we can get our 5-chamber view, and you can see the aortic valve coming in. Again, calcified sclerotic. Put color Doppler on, and this is one of the next points for me, is that you put color Doppler on, and I often do that just to try and find out what the direction of flow of the blood is, because when you look at this one, and I'm just not 100% certain they've got the right Doppler angle. What do you think?
Look, I would 100% agree with you on this. I think, and one of the caveats is people say an early peaking jet is mild, but I don't think that's always a reliable measure. If we go back to the color Doppler, one of my concerns here is you see inflow to the level of the valve, but you do not get a good jet of outflow.
Nice.
And when you're looking at continuous wave outflow, you want to see that jet, because otherwise you're essentially measuring into nothingness, and that's where you can underestimate it. So here, a significant amount of time has to, because we've got a disconnect between our visual estimation, which would put us in the moderate to severe category, and our gradients, which are not doing that. So what you'd want to do is really tilt your probe up and down to see if you can open up this angle in the 5-chamber view. Try different angles. So the 3-chamber view, the suprasternal, the subcostal, but here even the right parasternal, to be able to, and what you want to see is subcostal as well. So you can create a subcostal long axis view, particularly in smokers whose diaphragms are
get it. Nice.
But here, I would actually try to play with this 5-chamber view and sometimes move up or down a rib space, because you can forget about the ventricular cavity and focus on the aortic valve opening into the aorta. And I suspect that you may find a higher angle.
Fascinating. Cool. All right. Talk to me about Doppler traces. So we made a couple of measurements here. So we've got the big ones that I'm going to be looking at would be our mean gradients of 28, 28, and 25. They're kind of within ballparks of each other. I normally talk about being within 10% of each other. And we've got 3 traces have been done here. But again, I'm a little concerned in terms of optimization. I always want talk about needing to have the baseline at the top of the view, what you're interested in filling the screens, 3 cardiac cycles. But then it's about trying to make sure that the gain is correct and making sure your Doppler angle is correct, as we've discussed, and making sure that you're tracing it correctly. So, you're ignoring the fuzz. Again, is there anything else you want to add, or what do you think about some of this?
Look, I echo all of those points. I think of the most, and no pun intended there, but the most important point, I think, is the actual angle and seeing the color flow in the aorta. Once you have that right, I think averaging is always helpful. In aortic, in atrial fibrillation, you want to do 5 to 7 heartbeats because of the inherent beat variability. I think having a little bit of space just above the baseline to detect regurgitant jets as well is important. I think
Nice, absolutely.
adjusting your scale, so, and this is a principle we have in MR, whatever your velocity, you want to be maybe 20% above that velocity. So this dead space between the velocity of 4 to 5 is a scaling issue. And then when you draw your peak velocity and your curves, you're more likely to make an error. So to try to explode that out so you get to see the peak as well as you can. Increase your gains so that you have, we talk about the chin and the beard, and here you only have a chin, no real fuzziness of the beard. And the last thing will be your baseline to have a the low velocity filter reject nice and low so you can draw back down. One of the common errors that happen here sometimes can be eccentric jets of MR and aortic stenosis can overlap. And here it's looking at your temporal association between your QRS complex and your aortic outflow jet. So in MR, being a pansystolic phenomenon, it would start fairly early, whereas aortic stenosis, there's a bit of a lag before it starts.
And we're thinking that we're dealing with aortic stenosis, and they haven't done too bad a job.
I think it's reasonable.
I've done a lot worse. All right. And then what I really like to see is that someone's taking multiple views on this. And what the sonographer is trying to tell me here is that they're looking in multiple different angles. They're trying to look for that maximum gradient that they can. And here we've gone up to 36. You know, they had 28 in the first one. We've gone up to mean gradient to 34 in the next. They've got up to 36. Again, is that the best Doppler angle? And so how do you choose? What value are you choosing? First of all, we've just done it in the apical 5 chamber. As you said, they've done exactly what they should, and they've gone on to have a look at it in the apical 3 chamber, which looked like it was quite challenging. But here we can see an apical 3 chamber, again, the sclerotic valve, decent Doppler angles. I think we could have talked about having maybe a little bit more of a optimized colored jet. And they're not getting great, oh, excuse me, that's not that one. They're not getting great views when they're looking down. Even they're starting off with pulse wave, I think, here, and they didn't even try the continuous wave. But how do you choose? Which one are you going to choose? Are you averaging them, or are you choosing the peak?
No, I go for the one that gives me the highest gradient, basically, because I think the idea of averaging works if you're sampling appropriately, but if you're undersampling from certain views, then taking the undersampled views and the peak views are going to create a misconception of and underscore the severity of the aortic stenosis. My personal rule, and this is something I try to tell all my texts, is as soon as you're going to put the word moderate, then I want you to do every view. So I want right parasternal, I want suprasternal, I want subcostal, because looking at this case, my visual impression is that this is still severe aortic stenosis, and we may not be capturing the gradients. And just for the audience, we have a mean gradient of 36 millimeters of mercury. 40 is traditionally considered severe. We have a peak gradient of 54 millimeters of mercury, and 60 is traditionally considered severe. And our peak velocity is 3.7 meters per second, with 4 being a marker of severity. The other thing I always check, even if your EF is preserved, is your LVOT VTI. So your LVOT trace, for 2 reasons. So one being that low LVOT VTI, so traditionally LVOT VTI is less than 15, should alert you to low gradient aortic stenosis. That's not the case here. We've got VTIs of about 24. The second thing is, once your velocity of your VTI is more than 1.2 meters per second, so that's a high flow state, you need to adjust for your gradients by not using the simplified Bernoulli equation 4v squared, but 4 brackets v1 squared minus v2 squared, because your proximal velocity is going to overestimate it. So and most of the time this is done for you. And here you can see that our estimated valve area is 1.4 to 1.6 centimeters squared. Visually, it looks tighter than that. And when there's a discordance between visual assessment and your gradient assessment, I think doing the parasternal, all the additional views, one. And the second thing I use is contrast, because contrast enhances the Doppler signal, and you can, again, elicit higher gradients if need be.
Cool. All right, just lastly, the sonographer very nicely did what you were suggesting, which is lucky. And here we've got the first of the uses of the PDOF probe. It's not something that I think I've ever seen a doctor do particularly well, but it's great to see sonographers who often do it very well. And here we can see this is going to be in the apical 3 or 5 chamber view, because we've got the aortic stenosis flow below the line. And then in other views, we can see it coming above the line here, which would suggest that we're sitting up in the suprasternal or in a right parasternal view. I think there's the suprasternal. Again, trying to find maximum gradients. Here we're up to 38, which I think the maximum gradient that we found was up here in the suprasternal view.
So I think this is excellent work. I think this is exactly what you want to do. And once we're getting to 39 millimeters of mercury, you have to understand that the afterload the ventricle is pushing against is not only your aortic valve, but also your systemic blood pressure. So, here I think contextualizing the patient, because it's very arbitrary to say that 1 millimeter of mercury will decide if we operate or not. So I tend to have a low threshold for following up these patients or even considering operation on them, because you're going to reduce an afterload of here with a peak gradient. You've got a velocity of 4. So though your mean gradient is borderline, your peak velocity and your peak gradient both take you into the severe category. So this is a really elegant case of about how comprehensive guideline-based echocardiography changes management for a patient entirely. And it's irrelevant in the critical care space, because this is not a moderate aortic stenosis. This is going to have an impact on fluid resuscitation, on inotropes, on why a patient may in fact be hypotensive, and what therapeutic tools you have available at your disposal. So a suprasternal view, which completely changes management. And even in general practice in cardiology, it's not always common to do all the views, though we should be doing it. So I think this is a great illustration.
Well, Faraz, that was absolutely fantastic. Thank you very, very much indeed. It's been amazing just doing some echo reporting with Faraz. So thank you very, very much.
Thank you, Sam.
Cheers.
Thanks for the
Thanks,
invite.
guys.